talking now about medical ethics and how we try to navigate ethical, ethical dilemmas in our medical practices. And this talk actually was originally developed by one of our colleagues, Dr. Thomas Helmick, who's now an emeritus physician at Mayo Clinic, and I'd like to recognize and acknowledge his contribution to it. So I'd like actually for this to be fairly interactive, so I'll be asking you all to think about these questions. Basic outline is that I'll talk about some of the basics of medical ethics, what are the principles that we consider in this whole field of medical ethics. And for each of the principles, I'll have a case study for us to discuss. And maybe we'll end with some ideas on next steps. How do we develop our thinking? How do we develop our practices in this area as we come up with questions that patients have, or situations in which there's an ethical dilemma about what to do with an issue that one of our patients might have. So what is medical or healthcare ethics? It's really a set of moral principles, beliefs, and values that guide us in making choices about medical care. And I'm sure you've all probably seen these 4 basic principles, and we've actually discussed those a little bit with regard to some of the thinking about shared decision making, which is the idea of autonomy, the idea of justice, beneficence, or doing good to patients, and then non-maleficence, not doing harm. So we have the idea often that we express as first do no harm to your patients. And these, of course, can sometimes appear to come into conflict with each other because we talk, for example, about the patient has autonomy. They have their own agency. They have the ability to make their own decisions. But on the other hand, we have this idea of beneficence, that the physician or healthcare professional wants to do good to the patient. And you can see how that might conflict in the area of vaccination, for example, that we discussed. So the physician thinks the most helpful thing to do good to this patient or this child is vaccination, but the child or the person might think, I have my own autonomy, I'd much rather not have this vaccination. So how do we navigate these situations? So in terms of autonomy, the basic principle is to honor the patient's rights to make their own decision. So it comes with this idea that the patient has self-governance or self-rule. They have independence. They have liberty. In order for autonomy to be appropriately honored, though, the patient must be seen as being capable of rational thought. We must have to think that this patient can look at the set of circumstances that they are facing and make a decision that seems rational or well thought through. Of course, that can be a challenging thing to determine, but it's important that we at least considering this, that this is a patient that has that capacity for rational thought. The patient must not be coerced or manipulated. So this does, there's sometimes a situation in which the patient is there, maybe they're there with a family member, and it's important that the physician or healthcare worker be able to read the interaction that's occurring to make sure that the patient isn't in a situation where they're being forced to do things that are against their will, or information is being withheld from the patient or the patient's understanding that's important for them to make a rational decision. Sometimes we are faced with this when we're in a situation, for example, where the patient and the healthcare worker may not speak the same language. And you may have come across this where it's often the case that a relative might offer, I can help translate. And And it's often the case where within the healthcare system that we actually prefer that it's not a relative or healthcare worker that's doing the translation. Because the physician or other healthcare worker may have no idea. I said it's not the relative that's doing the translation for the healthcare worker. And this, of course, is important because the healthcare worker who does not understand the language the patient understands may have no idea what is being communicated when they say one thing and it's being translated to the patient. So typically, the preferred option is that we have an independent, trained medical, just get some water. We have an independent, trained medical translator so that we have confidence within the healthcare system that the right things are being communicated. And sometimes, I know in our healthcare system in Ghana, we'll often try to find a colleague healthcare worker who speaks the language that we don't understand. So at least we're relying on someone who's a trained healthcare worker to do this. So that idea of coercion manipulation is important. And the goal really is that the patient is able to make a fully informed decision. So we're back to the discussion that we just had about shared decision making. The decision hopefully is fully informed. So autonomy is really important. So here's an example of a question about autonomy. We have a 45-year-old person with hypertension and diabetes who has end-stage renal disease. They are deteriorating and they want to go on dialysis. But the patient's family does not agree with his decision. So our questions are there limits to a person's autonomy? Anyone want to suggest or to respond to that question? Do you want to speak to that? This word.
So in this patient, our first 5-year-old has hypertension years and has end-stage renal disease and is currently deteriorating. So, for the patient to go to fully have to means that the patient should be capable of rational thought. So, is this patient capable of that? Are there any complications currently as the patient is deteriorating that prevents the patient having rational thought?
Thank you. So it's important that the patient will be able to assess the patient for the ability to make an appropriate decision about his dialysis. Any other considerations?
I wouldn't say it's a limit on the patient's autonomy. Patients, once the patient was sound minded but they were able to make that decision concerning his health, I think the patient can do that. But there are other factors that limit the execution of the result of the patient's decision. Especially now, certain resources are oftentimes limited. These patients can make the decision to undergo dialysis, but financial constraints might make it difficult to execute that decision. So that might be where the family is coming from. So we can document that the patient has opted to undergo dialysis, but if the patient is unable to bear the cost of it, then alternatives will have to be placed on the table and then something work out in the best interest of the patient based on what the system can allow and what the patient can afford.
Thank you very much. So clearly situations in which the decision making is complicated because it's not only a question about what the patient wants, but it's a question about what can operationally happen. Was that the answer?
So this patient has end-stage renal disease is deteriorating. But from the onset of the diagnosis of this patient, if this patient had probably had a palliative consult. We know that from the time that the patient is diagnosed, they may have discussed the options of giving the authority for someone else to make a decision in the case when the patient is not able to. So from the onset, maybe it was done and it was not done. If it was done, you wouldn't have this situation.
Really important is that at the time that we identify this patient has end-stage renal disease, it's important to begin to have the conversations about what might happen in the future. Okay. And how that might in the future influence the person's ability to make decisions so that there is a plan for that time when it comes. So I'm going to stop here, we'll keep going. So our next basic principle is justice. So justice is the idea that we want to be fair and treat like cases alike. Okay. So we want to treat people equitably. In similar situations and conditions, we want to try to treat people alike. We want to try to fairly distribute resources. So here we have a 6-year-old non-registered patient who developed severe sepsis and pneumonia and acute respiratory failure, but there's only one available pediatric ventilator at your hospital. And a premature set of 34-week-old twins, Penny and Kakra, are soon to be delivered. Questions. How do you ensure community resources are being used sensibly and fairly? And how do you factor in hospital budgets, insurance coverage, and prognosis? Thoughts here? Anyone wants to make some comments?
Save it for pain.
Alright? Save it for pain. What factors go into that? What factors go into this idea of saving it for Penny and Hakra? Just pain.
My own thing to be fair to try and encourage patients to have of life-saving healthcare in the anticipation of probable patients in life later. It is possible that the 6-year-old the intervention can be made for the 6-year-old and he will recover before the premature twins are born and will need the respirator. It won't be fair to deprive him of that, hoping that you keep it for them.
Excellent. So the question of timing here. Is there anything else? I don't do OBGYN, family practice, any other considerations in terms of the age of these premature twins?
I think that you can take into consideration that there are potential other options for the 34-week-old twins, such as CPAP, that they'll be able to do well on. And as has already been mentioned, a potentially brief intervention, which is going to be life-saving for the 6-year-old, will be, it's the only option, will be the only option. They're already in acute respiratory failure. And so if you have an alternative therapy that may work well for the other ones, saving this additionally makes the justice issue a little bit easier. Saving it would not be ideal.
Thank you.
We should also think about pulling in of resources. We shouldn't always focus on the hospital. There could be other facilities in the nation, or maybe that we can consider for the
consider another facility for the elective cesarean section, for example, or that the delivery of the premature twins. We'll take one more comment.
I think another option would be to consider delaying the delivery of the twin gestation so that the 6-year-old instead could be sold.
Thank you. So really the primacy of the urgency for this 6-year-old, it seems as though is our consensus here. So we've done a little ethics consult with this group, and we arrived at some recommendations that hopefully will be helpful in the care of these patients. So our next basic principle is beneficence, the idea that we want to act in the patient's best interest. We've spoken about this, the needs of the patient come first, and the best interest of the patient is the only interest to be considered. We want to promote our patients' health and well-being. So in this case, we have a chronically ill 65-year-old female with cervical cancer who arrives into the emergency department with a fever and low blood pressure. She has altered mental status and her family are unavailable. They're in transit. I was learning yesterday, maybe they're in Wa and the patient is in Tamale, and there's 6 hours of travel between them. What assumptions does one make in the emergency care setting? And the other question is, does beneficence always trump justice? So what assumptions does one make in the emergency care setting when this patient has appeared, has presented to the emergency department and appears as though she needs some care immediately, but there isn't any family to provide guidance or consent for the care?
Yes, so we understand that in emergency settings, consent is implied, and you go ahead and you do what's just needed for the patient.
Great, thanks very much. So emergency settings, consent is implied, and we can do what is best for the patient.
Looking at the scenario, patient has an altered mental status, and in this case, the physician there has to do what's best for the patient by making sure he or she deals with the fever and low blood pressure before, maybe afterwards, the patient is able to make decisions on her own. Then she takes it over from there.
Great, thanks very much. What about the situation I was faced with actually not very long ago, a couple of weeks ago? I was in a hospital service, and there was a patient that we had concerns about whether they might have mild cognitive impairment or early dementia. And he was needing an emergency procedure. And in that circumstance as well, I think we had the choice, we had to make the choice, and so what we ended up doing was documenting in the medical record that we did not feel that the patient had the ability, the capacity to make this decision. We did not have a family member available to approve the decision, and so because of the urgency of the decision, we were going to move forward with this procedure that we felt was essential for the patient's care. So very similar, I think, ideas around this idea of beneficence, trying to do the very best for the patient, even when it's an emergency situation and they cannot provide the consent that we would normally expect to get. So let's move on to the other side, non-maleficence, this idea of first do no harm. And this is often balanced with beneficence. We want to do good, but we also don't want to harm patients. We recognize, of course, that many of the interventions that we do in medicine come with risks, or they may come if they're medication with side effects. And so there's always a balance. And it demands that we maintain our skills and knowledge, that we know how to prevent side effects, for example, of particular medications, that we are prepared to address side effects if they occur, and that we are continuously educating ourselves about the very best treatments that we can provide. So here's an example here, a 22-year-old, the 3 para 2 with preeclampsia, deteriorates. In the 33-week gestation, breech baby develops severe bradycardia. The first-year medical officer at 3 a.m. performs an emergency C-section, which he has never done before, and the mother dies in the operating room. The infant survives. The father blames the doctor for his wife's death. So has the physician breached the do no harm principle? So there seems to be a consensus of yes. Anyone want to speak to it?
Also has risk. So in as much as his intention was to save a life, that didn't happen. So I don't think that he is back.
Yes, Katra.
This is a difficult one because his intention was to try to save both lives, but he didn't really have the training necessary, and so it would then come down to what was requested by the mother and the father at the time as far as which of the lives to prioritize. And in emergency medicine, we do something called an emergency hysterotomy, where we do a procedure, it's a C-section, emergency C-section, but when in an attempt to save the mother's life, and with the hope to save the baby, but it's in an acute situation, and we learn how to do that. We're not obstetricians, we're not doing it but it is the understanding is by getting the baby out, we might save the mom. In this situation, the goal was to save the baby, because the mom was probably not in all that much stress. So this is a challenging one.
Okay. I think we have a couple of additional comments here.
Thank you very much. I think to add, it would have to be, the whole situation and the context would have to be analyzed for us to see whether he has actually breached it or not. And from the scenario, the mother is deteriorating, so eventually we could have lost both the mother and the baby. And we'd also want to find out if the doctor had tried to get a senior person on ground to come and perform the surgery or not. Or his hands were tied that he had no other choice than to do it. And then again, this may be his first time doing the surgery, but he's probably assisted a number of times. So he may have some skill to still be able to go ahead. So the whole situation will have to be analyzed, and then we'll come to the conclusion as to whether he is culpable or he's actually done something good for them, rather than losing to at least he saved one.
Okay, in the interest of time, we'll keep going, but clearly this touched on her, isn't it? So there are common areas of ethical conflicts. There's end-of-life care, conflicts of interest, healthcare rationing. There was a time, and I don't know what the exact state is in the United Kingdom, for example, where whether or not you were considered as a candidate to go on dialysis depended on your age. And young people who were thought to have more sort of acute renal failure were prioritized over older people who needed dialysis because at that time in the system, there was limited capacity for long-term dialysis. And I'm sure that is similar here as well. Medical mistakes can occur, and how those are addressed is really important as well. There's issues related to confidentiality. Maintaining patient confidentiality is incredibly important. And in many institutions, if we find that a staff member isn't maintaining patient confidentiality or has breached patient confidentiality, that is considered a very egregious offense. And there's of course areas related to, for example, abortion, induced abortion, where there's often ethical questions that need to be addressed. In the rural setting, there are particular issues: limited economic resources, reduced health status of patients. Sometimes patients present with very late stage of their disease. We have limited availability and accessibility of healthcare services. And there are cultural and personal values that sometimes seem inimical to individuals' health and have to be addressed almost at the community level. The community awareness of health is really important for the healthcare system. You may have dual and overlapping professional-patient relationships in a setting where it's a small community, and it's all like everybody knows everyone else, and sometimes it seems like they're all related to everyone else, and so patient confidentiality may be a challenge as well. And then there may be more caregiver stress, so people who are maybe not fully trained, feeling that they're in a place where they're having to practice above their level of training, for example. So I'd like to give you, we only have a minute to go, I'm going to leave you with these questions. So think about what are some situations in which ethical dilemmas arise in your current practice. And I think I'd like you to think, what principles, how do some of the principles we've discussed, how can you use them to guide the resolution of these particular dilemmas? And in terms of next steps, I think it's really important that we advocate for the idea of a medical ethics committee. You know, many hospitals and health institutions have them. It might be something to think, even if it's not present, if having a structure or a way to pull together leadership and the right people to have these discussions when necessary, I think it's really critical. There's value to having multidisciplinary input. We saw situations in which it was helpful to hear a pediatrician's perspective, an OBGYN's perspective, for example, and that can be very helpful. And having a structured approach to the ethics consultation can be really helpful. Find a mentor or colleague to discuss, share, learn about these principles, because they can be incredibly important to do that. And I think we didn't talk about research, but of course these ethical principles are very important when it comes to research, where often when patients agree to be part of a research study, they're in a vulnerable state. And so it's important that we are holding the highest principles of medical ethics as we consider the types of research that's done. And we typically have institutional review boards or institutional research boards that will review research that is going to be done or that is proposed to be done at the institution and approve or reject or request changes with the views of the participants in the research study as the primary goal, the protection of the participants in research studies. So that's something I think as many of us are in training, maybe doing professional degrees that require research studies. It's really important to think about the ethical aspects of those research studies as well. So thanks very much. Here's my contact information. If you're interested or have questions, we're happy to answer any questions. Please don't contact Tom. Since he's involved in this, he's retired.